Started your timer, and here is your question. Right. If you have read and understood, considering it critical care scenario, kindly tell me, how do you plan to or intend to manage this patient?
Okay, I'll manage the patient using the CRIPS protocol. So
Yes.
I'll admit the patient. I'll check the airway. The patient is talking, that means the airway is patent. And then I'll assess the breathing of the patient. While checking for the breathing of the patient, I will note the respiratory rate, check the trachea, note the chest expansion, and then also auscultate the chest. The patient is having a respiratory rate of 30, so I want to commence him on oxygen. Then for the circulation, the patient is tachycardic and hypotensive, so I will assess him, check the JVP to measure if there is I don't expect any raised JVP. Then I will listen to his cardiac, auscultate the heart. Then I will set 2 wide burst cannula to give him fluid, and then also 6 samples for full blood count, electrolyte and creatinine, and then also for group and cross match also for him. I will pass catheter for him. I will give blood, I'll give fluid, but I won't give so much fluid so as to maintain hypotensive, permissive hypotension. Then for the disability, I will check the patient. The patient is confused already, so that means it will only be it will only be responding to verbal response. Then for I also
Yes, you said you'll pass the catheter. How frequently would you monitor the patient's output?
I'll monitor the urine output hourly, ma.
Very good. Okay, what test would you do to confirm your diagnosis?
Yes, I want to do an abdominal CT angiogram with contrast.
Yes. Okay. What is the provisional diagnosis that you suspect? What is this pulsatile? Yes, please.
Yes, this pulsatile mass in his abdomen, I'm thinking is the abdominal aorta, so it's likely an aortic aneurysm.
Okay. So what are the risks with aortic aneurysm that you should be conscious about?
The risk factors for aortic aneurysm includes diabetic patient. The patient is also a smoker. If he's also hypertensive, all those ones put him at risk. And then if there's any previous history of infection, or could also predispose him to having a abdominal aortic aneurysm.
Okay. Right. But there are more, you can tell me.
Then hypercholesterolemia also is a risk factor.
Okay, these are the risk factors. But what I wanted to know about the complications, like
okay, the complications is ruptured.
Yes.
And if it's ruptured, could lead to death because patients can bleed massively from the rupture.
Okay. Why this vessel, like if you transect it, you cannot stop the bleeding in case of aortic aneurysm?
I didn't get the question, ma.
Yes. What is deficient in the blood vessel or in the blood, because of which once you're transecting the blood vessel, it does not stop bleeding?
The coagulating factors likely are going to be reduced in the patient. So that may make the patient not to and then the vessels or wall is also
yes, that
fragile.
I want to hear. Yes. Okay. Can you tell me what type of aneurysm are you aware of or you know of?
Okay, there could be
True
a
and false. Yes.
circular aneurysm.
Yes.
I can't remember the second one.
Okay, if you divide
Then
them
mycotic
broadly,
aneurysm
true
also.
aneurysm and the false aneurysm. Can you please give the example? And then there is another one, infective aneurysm. If you can give the example of that, please.
Okay, infection is a mycotic aneurysm.
Yes.
True aneurysm involves the whole wall of the abdominal of the vessel is affected. While in false aneurysm, there's only affectation of the tunica media and also the tunica intima media, and then the intima
adventitia from inside to outside. Okay, right? Can you please tell me, because patient's blood pressure is 70/40 hypotensive, how do you intend to take care of blood pressure or hemostasis of the patient?
Yes, I'll give the patient fluid, at least 1 liter fluid, and then also get blood ready, also 6 units of blood ready, and then I'll transfuse as the need be.
Okay. Can you tell me how this patient's vessels will maintain the hemostasis? What is the mechanism?
To maintain the hemostasis, there will be once there is injury, there will be vasoconstriction.
Yes.
Then there will be platelet and aggregation.
Yes.
Then there will be activation of the clotting factor leading to clot formation. And then after the hemostasis has been secured, after some times there may be fibrinolysis. Fibrinolytic pathway may be activated so as to clear the blood vessels, the clots, so that blood can continue to flow in the vessel.
All right, good. Can you please tell me how would once you'll be operating on the patient, how a surgeon, a vascular surgeon, can interfere with the hemostasis of the vessel or hemostasis of the person, body, or inside? Yeah.
The vascular surgeon will need to secure hemostasis both proximally and distally while doing the surgery, and then we now excise the aneurysmal part, and then do a vascular anastomosis to create continuity.
Yes, but then how vascular surgeon contributes or interferes with the mechanism of hemostasis? Because
the vascular surgeon,
yes,
the vascular surgeon, if it's not gentle with handling the tissue, it can cause further injury. It can also affect dislodge of clot that has been formed.
Yes,
and then
clot
if patient,
or a plug, you should say platelet plug.
Platelet plug that's been that's been formed, and then patient is also not well. There is so much fluid that's been, maybe there's massive transfusion, or patient is exposed unnecessarily, there could be also affectation of the coagulation pathway in the patient.
Okay, you said you'll give the blood to the patient. How much blood units are you do you think patient would need for this surgery? Secondly, why would you ask for blood as a whole, but not for the blood products or any other plasma expanders that you could use?
Okay, the patients will need at least 4 to 6 units of blood for the surgery. Apart from the whole blood that will be required for the patient for the procedure, I also get ready fresh frozen plasma.
Yes.
Also for the patient, and then if possible, platelet concentrates to be given to the patient, so as to prevent to give these supplements that will be lost during the procedure.
Very good. Okay, can you please tell me what are the complications post-operatively that you can expect in this patient?
The post-operative complication, patients could have shock, could develop hemorrhagic hypovolemic shock.
Before
there
that,
could be mesenteric ischemia. in the patient. The patients can also have cardiac arrhythmia or cardiogenic shock.
Yes.
Then
there could
there
be
could
malpositioning of the graft.
The malposition of the graft.
Yes, there could be arterial dissection. There could be endoleak. There could be ectogenic injuries. Yes.
Okay.
Yes. So yes.
Then there could be anastomotic leak.
Yes, please. Yes. So what are the medical complications that can arise?
Medical complications.
Yes.
I didn't get the
medical complications that can arise after this surgery. There could be acute congestive cardiac failure. There could be acute renal failure. There could be more. You can tell me.
Okay, ma. All right. I get the
good.
Other complications that are not related to the surgery.
Yes, because of the procedure, related to procedure. Very good. Okay, good.